Welcome back to Bugs and Beyond, your one-stop shop for everything infectious diseases.
That's right.
Today we're taking a deep dive into the world of TB treatment.
It's
It's a complex topic,
Yeah.
but don't worry, you're in good hands.
That's right. We'll guide you through everything you need to know, from the basics to the latest advancements.
And for those of you who are already familiar with TB, get ready for some aha moments as we uncover some surprising facts and expert insights.
We'll break down the complexities of TB treatment so you can walk away feeling confident and informed.
Exactly. So before we jump in, let me ask you, dear listener, what's one thing you're grateful for today? Take a moment to reflect on something positive in your life, big or small. It's amazing how a little gratitude can shift our perspective and make us more receptive to learning.
Absolutely.
Okay, ready to dive into the world of TB?
Let's do it.
All right, now let's set the stage. TB, or tuberculosis, is a bacterial infection that primarily affects the lungs but can also spread to other parts of the body. It's a global health concern, but here in the U.S. we've seen a significant decline in cases over the years. But here's the catch. TB is still a threat, especially for certain populations.
That's right. In fact, the CDC data shows that in 2020, the majority of TB cases in the U.S. were among people born outside of the country, highlighting the global nature of this disease. And here's a fact that might surprise you. 1 in 4 people worldwide are infected with the TB bacteria.
1 in 4. That's a staggering number. So even though we've made progress in the U.S., it's clear that TB is still a force to be reckoned with. Now, before we get into treatment, let's clarify a crucial distinction: latent TB versus active TB. Can you explain the difference for our listeners?
Absolutely. Think of it this way. You have a seed planted in your garden. It's there, but it's dormant, not growing. That's similar to latent TB infection, or LTBI. You have the TB bacteria in your body, but it's inactive. You don't feel sick, and you can't spread it to others.
Okay, so it's like a silent passenger.
Precisely. But here's the catch. Just like that seed in your garden, latent TB can sprout under certain conditions. That's why identifying and treating LTBI is so crucial. It prevents the infection from progressing to active TB disease, which is when the bacteria start multiplying rapidly, causing symptoms and making you contagious.
So it's about preventing that seed from blossoming into a full-blown problem.
Exactly. Now, if you're wondering how we even know if someone has TB in the first place, well, it's not as simple as just looking under a microscope. TB diagnosis has evolved beyond traditional methods.
You're right. I remember the source material mentioned some newer, faster techniques for identifying TB bacteria. What are some of the key advancements in TB diagnosis?
One of the most significant advancements is the use of liquid culture systems. These systems are like high-tech incubators for bacteria, allowing them to grow much faster than traditional methods. In some cases, they can cut the wait time for a diagnosis from weeks to just a few days.
Wow, that's a huge time saver.
Yeah.
It's like speeding up the detective work.
Exactly. And then we have genotypic methods, which analyze the bacteria's genes to identify specific mutations that confer drug resistance. This information is crucial for guiding treatment decisions.
So it's like getting a sneak peek into the enemy's playbook.
You got it. This genetic information helps us tailor treatment regimens to effectively target the specific strain of TB we're dealing with.
Okay, let's say we've identified a case of active TB. What's the game plan? How do we tackle this bacterial foe?
That's where the RIO-PE regimen comes in. Rifampin, isoniazid, pyrazinamide, and ethambutol. Each of these drugs plays a specific role in knocking out those TB bugs.
Okay, let's unpack this RIPE regimen. First up, rifampin. What's its claim to fame?
Rifampin is like a saboteur. It infiltrates the bacteria's ranks and disrupts their ability to produce essential proteins. It's one of the most potent weapons we have against TB. And get this, researchers are even exploring higher doses of rifampin to ramp up its effectiveness.
So they're really trying to hit those bacteria where it hurts. But what about side effects? Are there any downsides to using this powerful drug?
Like any medication, rifampin can have side effects. One thing we watch for is liver toxicity. It's not common, but it's something we monitor closely. And some people experience flu-like symptoms, which can be a bit of a nuisance.
Okay, so it's powerful, but not without its quirks. Next in line, isoniazids. What's its role in this bacterial battle?
Isoniazid, or INH for short, is like a demolition crew. It targets the bacteria's cell wall, weakening their defenses and making them vulnerable to attack.
Interesting. So it's like breaking down their fortress.
Yeah.
But I imagine there's a trade-off, right? What about side effects?
Yes. Unfortunately, isoniazid can also affect the liver, so we monitor liver function closely. And it can sometimes cause peripheral neuropathy, which can lead to numbness and tingling in the hands and feet.
Okay, so another one to watch carefully.
Right.
Onto the P in IEPE pyrazinamide.
Pyrazinamide or PZA is a bit of an enigma. It's been a mainstay of TB treatment for decades, but we're still not entirely sure how it works. It's thought to act on the bacterial cell membrane, but more research is needed to unravel its mysteries.
A mystery drug.
Yeah.
I love it. But it wouldn't be a very effective drug if it came with a host of nasty side effects, would it?
Not at all. Pyrazinamide is generally well tolerated, but it can cause elevated uric acid levels, leading to joint pain in some people. And again, liver toxicity is a potential concern.
So another one to keep an eye on. Finally, we have ethambutol. What's its contribution to this TB fighting team?
Ethambutol, or EMB, is like a master architect. It disrupts the construction of the bacteria's cell wall, preventing them from building strong defenses.
So it's like sabotaging their construction project. But I'm guessing ethambutol comes with its own set of cautions.
Of course. The most concerning side effect of ethambutol is ocular toxicity, which can affect vision. Regular eye exams are crucial for patients taking this medication.
Okay, so we've covered the initial 2 months of treatment with the RIPE regimen. What happens after that? Do patients continue on all 4 drugs?
That's a great question. If the patient is responding well to the RIPE regimen, we typically adjust the treatment after the first 2 months. We discontinue pyrazinamide and ethambutol, and the patient continues on just isoniazid and rifampin for at least another 4 months.
So a bit of a reprieve from the side effects, hopefully.
Potentially, yes. But it's important to remember that the total duration of treatment can vary depending on several factors, including the site of infection. For example, meningitis and bone TB typically require longer treatment durations to ensure we completely eradicate those stubborn bacteria.
Makes sense. Now imagine this, those first-line drugs, the ones we've been relying on, suddenly stop working. That's the terrifying reality of MDR-TB, or multi-drug-resistant TB.
It's a major challenge, and unfortunately, it's a growing problem worldwide. MDR-TB arises when the TB bacteria develop resistance to at least 2 of the most potent first-line drugs, isoniazid and rifampin.
So the I and the R in RPE are basically useless. That sounds like a nightmare scenario. How does that even happen?
It's often a consequence of incomplete or inappropriate treatment. Imagine someone starts TB treatment but doesn't take their medications consistently or stops taking them too early.
Oh, I see. So the bacteria that survive, the ones that might have some level of drug resistance, they have a chance to multiply and create a whole population of drug-resistant TB.
Exactly. It's survival of the fittest, but in this case, fittest means drug-resistant. And this makes treatment much more challenging and expensive because we have to turn to second-line TB drugs, which are often less effective, have more side effects, and require much longer treatment courses.
This sounds like a public health nightmare.
Mm-hmm.
So what do we do when we're faced with MDR-TB?
It requires a multi-pronged approach. Firstly, it's essential to consult with TB experts. They can help tailor a treatment regimen based on the patient's individual circumstances and the drug susceptibility profile of the TB strain.
Okay, so expert guidance is crucial. What else?
Secondly, we need to consider therapeutic drug monitoring, or TDM. This involves measuring drug levels in the patient's blood to ensure they're receiving adequate doses and that the drugs are being properly absorbed and metabolized.
That makes sense. You want to make sure the drugs are actually reaching the bacteria and doing their job. But let's talk about these second-line drugs. What are we dealing with here?
They're a mixed bag, to be honest. We have older drugs like injectable aminoglycosides, which can be effective but have significant side effects like hearing loss and kidney damage. And then we have fluoroquinolones, which are oral medications but can also have serious side effects like tendon rupture and heart rhythm problems.
Okay, so it seems like a delicate balancing act between effectiveness and safety. What are some newer drugs used for MDR-TB?
We have some newer drugs like bedaquiline, predominid, and linezolid that offer hope for MDR-TB patients. They work in different ways to attack the bacteria, and they've shown promising results in clinical trials.
This is really encouraging news. It sounds like the landscape of MDR-TB treatment is constantly evolving.
It absolutely is. Research is ongoing, and new drugs and treatment strategies are constantly being developed. But one thing that remains constant is the importance of directly observed therapy, or DOT, in MDR-TB cases.
Okay, I'm intrigued.
Okay.
Tell me more about DOT. Why is it so crucial in MDR-TB treatment?
Think about it. With MDR-TB treatment can last anywhere from 6 to 24 months, depending on the drug regimen. That's a long time to take a cocktail of medications, some with potentially severe side effects.
I can see how that would be incredibly challenging for patients.
Exactly. There's a high risk of them missing doses or stopping treatment altogether, which can lead to treatment failure and further drug resistance.
That makes sense. So how does DOT address this challenge?
With DOT, a healthcare worker directly observes the patient taking their medication each day, ensuring they don't miss any doses and that they're adhering to the treatment plan. It might seem like a lot of effort, but it's absolutely vital to prevent those negative outcomes we talked about.
So it's about providing that extra layer of support and accountability to help patients stay on track with their treatment.
Precisely. It's a team effort, and DOT plays a crucial role in MDR-TB management. Now let's shift gears for a moment and talk about some of the potential pitfalls in TB treatment, because understanding these mistakes can help us prevent them and improve patient outcomes.
Okay, I'm all ears. What are some of the things that can go wrong, even with the best intentions?
One critical error is adding a single drug to a failing regimen. It's tempting to think that adding another drug will somehow make things better, but in reality, it can actually worsen drug resistance. Remember, TB bacteria are incredibly adaptable, and if you expose them to a single drug, they're likely to develop resistance to it.
So it's like trying to put out a fire with gasoline. It
Sure.
just makes things worse.
The perfect analogy. Another common mistake is starting with an inadequate initial regimen, like using only isoniazid and rifampin instead of the full RIPE regimen. This can give the bacteria a chance to develop resistance to those key drugs right from the start.
So it's crucial to hit them hard from the get-go with the full arsenal.
Exactly. We also need to ensure an adequate duration of treatment. Stopping treatment too early, even if the patient feels better, can lead to relapse and the emergence of drug resistance.
I'm sensing a theme here. Consistency is key in TB treatment.
You got it. And of course, failing to identify drug resistance early on can be a major pitfall. It's essential to perform drug susceptibility testing as soon as possible to guide treatment decisions.
So it's like going into battle without knowing your enemy's strengths and weaknesses.
Very well put. We also need to be vigilant about patient non-compliance. If a patient isn't taking their medications as prescribed, it's essential to address the reasons behind it and provide the necessary support to improve adherence.
So it's not just about prescribing the right medications, but also ensuring they're actually being taken properly.
Exactly. And finally, failing to provide isoniazid preventive therapy, according to established guidelines, can also be a missed opportunity to prevent active TB disease in those with latent TB infection.
So it's about prevention as well as treatment.
Absolutely. Preventing TB cases in the first place is just as important as treating existing cases. Before we move on to other aspects of TB, let's have a quick quiz to test your knowledge so far.
I love a good quiz. Okay, listeners, you ready? First question. Which of these is not one of the 4 first-line drugs used to treat active TB? Is it A, rifampin, B, isoniazid, C, ethionamide, or D, pyrazinamide?
That's a great question to start with. It tests whether our listener remembers the core components of that RIPE regimen we discussed. The answer, of course, is C, ethionamide. That's a second-line drug, often reserved for cases of drug-resistant TB.
Excellent. Let's try another one. Which of the following statements about MDR-TB is false? Is it A, it's caused by a bacteria resistant to at least isoniazid and rifampin? B, it's easier and less expensive to treat than drug-susceptible TB? C, it often arises from incomplete or inappropriate treatment? Or D, it requires prolonged treatment with second-line drugs, which can have more side effects?
This one highlights the seriousness of MDR-TB and why preventing it is so crucial. The false statement is B, MDR-TB is definitely not easier or less expensive to treat. It's a much more complex and challenging situation.
Great point. Okay, one last question before we wrap up this part of our deep dive. Which of the following is not a potential side effect of TB medications? Is it A, liver toxicity, B, peripheral neuropathy, C, ocular toxicity, or D, hyperglycemia?
This one tests the listener's recall of those important side effects we discussed earlier, and the answer is D, hyperglycemia. While some TB drugs can affect glucose metabolism, hyperglycemia or high blood sugar is not a typical side effect.
That's right. We focused on liver toxicity, peripheral neuropathy, and ocular toxicity as the major concerns.
You've done an excellent job summarizing those key points.
Well, I couldn't have done it without you and your expertise. We've covered a lot of ground in this first part of our deep dive into TB treatment, but there's still more to explore. Stay tuned for part 2, where we'll delve deeper into the nuances of MDR-TB, discuss those game-changing new drugs, and tackle the complexities of paradoxical reactions in people with HIV.
I can't wait to share more insights with you.
And remember, dear listeners, if you're enjoying this deep dive, please like, subscribe, and share this podcast with anyone interested in learning more about infectious diseases. We'll see you in part 2.
Welcome back to Bugs and Beyond. I'm excited to continue our exploration of TB treatment.
Me too. Last time we left off on a rather sobering note, the rise of multi-drug-resistant TB.
It's a serious challenge, no doubt. But before we dive back into the complexities of MDR-TB, let's take a moment to appreciate the progress we've made in TB treatment overall.
That's a great point. It's easy to get caught up in the challenges, but it's important to acknowledge the victories as well.
Absolutely. We have effective treatments for drug-susceptible TB, and we're constantly making strides in the fight against MDR-TB.
Okay, so let's talk about those strides. You mentioned some newer drugs for MDR-TB last time, bedaquiline, pretomanid, and linezolid. These seem like game changers, but I imagine they come with their own complexities.
You're right, they're not without their challenges. Let's start with bedaquiline. It's a fascinating drug that works by targeting the bacteria's energy production.
So it basically throws a wrench into their power supply.
Exactly. Bedaquiline has shown remarkable efficacy against MDR-TB, especially when combined with other drugs. But it's not a free pass. It does come with a risk of heart-related side effects, so we have to be very cautious when prescribing it.
That makes sense. It sounds like a powerful tool, but one that needs to be used responsibly. What about pretomanid? What's its story?
Pretomanid is another promising drug. It works by inhibiting the synthesis of mycolic acid, a key component of the TB bacteria's cell wall. And it's been particularly effective as part of a new 3-drug regimen for highly drug-resistant TB.
A 3-drug regimen? That sounds promising. What's the big deal about that?
Well, older MDR-TB treatment regimens often involved a lot of drugs, sometimes up to 8, and many required injections. Imagine taking that many medications for months or even years.
That sounds incredibly difficult to manage, both for patients and healthcare providers.
It is. This new 3-drug regimen is a major step forward because it's all oral, shorter in duration, and seems to have fewer side effects. It's a real game changer for patients with highly drug-resistant TB.
That's fantastic news. Okay, what about linezolid? I know that one's used for other infections too. What makes it useful for fighting TB?
That's right. Linezolid has been around for a while, and it's been used to treat various infections, including some tough ones like MRSA. It works by inhibiting protein synthesis in bacteria, which essentially stops them from growing and multiplying.
So it's a versatile weapon in our antimicrobial arsenal.
Precisely. And it's been shown to be effective against MDR-TB as well, often in combination with other drugs. But it's important to note that linezolid can also have some side effects, including a decrease in blood cell production and potential nerve damage.
Okay, so it's another one that requires careful monitoring. It seems like there's always a trade-off between effectiveness and safety when it comes to these powerful drugs.
That's a keen observation. It's a constant balancing act, weighing the potential benefits against the potential risks. And that's where therapeutic drug monitoring, or TDM, comes into play. We touched on this briefly last time, but I think it's worth exploring further.
Yes, please. Remind our listeners what TDM is and why it's so important in TB treatment.
Essentially, TDM involves measuring the levels of TB drugs in a patient's blood. We do this to ensure that they're getting enough of the drug to be effective, but not so much that it causes harmful side effects.
So it's like finding that Goldilocks zone, not too much, not too little, but just right.
Exactly. TDM helps us individualize treatment based on the patient's unique metabolism and response to the drugs. It's especially crucial for drugs with a narrow therapeutic index.
I remember you mentioning that term earlier. What does it mean exactly?
It means that there's a very small difference between the dose that's effective and the dose that's toxic.
Okay, so you really have to walk a tightrope with those drugs, making sure you're hitting the sweet spot.
Precisely. And TDM helps us do that by providing real-time data on the patient's drug levels. It's a valuable tool for optimizing treatment and minimizing risks, especially in complex cases like MDR-TB, where we're often using multiple drugs.
It sounds like TDM is playing a key role in the shift toward personalized medicine, tailoring treatment to the individual patient.
It's a great example of how we can use laboratory data to make more informed treatment decisions, improving outcomes and minimizing harm. Now, before we move on, I want to circle back to a topic we briefly mentioned earlier, paradoxical reactions, or IRS, in people with HIV who start antiretroviral therapy.
Ah, yes, those paradoxical reactions. They've always intrigued me. It seems counterintuitive that the immune system would cause more problems when it's supposed to be recovering. Can you shed some light on this phenomenon for our listeners?
Of course. When someone with HIV starts antiretroviral therapy, their immune system begins to bounce back. But in some cases, this immune reconstitution can trigger an exaggerated inflammatory response, especially if the person had an underlying infection like TB before starting RT.
So it's like the immune system is suddenly waking up from a long slumber and overreacting to the presence of these infections.
That's a great way to put it. It's thought that the immune system, after being suppressed for so long, may misidentify certain components of the TB bacteria or other pathogens, leading to this excessive inflammatory response.
Okay, that makes sense. So what are some of the red flags that might signal that someone is experiencing IRIS?
It can manifest in various ways, depending on the infection and the organs involved. Some common signs and symptoms include fever chills, sweats, swollen lymph nodes, worsening cough or shortness of breath, skin rashes, and even neurological symptoms like headaches or confusion.
Wow, that's a wide range of potential problems. So it's not always easy to spot iris.
It can be challenging because the symptoms often mimic those of the underlying infection. It's like trying to tell the difference between a forest fire and a controlled burn.
Okay, so you really have to look closely to figure out what's driving those symptoms. So how do we differentiate between a true worsening of the infection and an inflammatory reaction?
It requires careful clinical judgment, taking into account the patient's history, physical exam findings, laboratory tests, and imaging studies. And timing is an important clue. Iris typically occurs within the first few weeks or months after starting ART, although it can sometimes occur later.
Okay, so timing is a key piece of the puzzle. What about treatment? How do we manage irises once it's diagnosed?
The approach depends on the severity of the reaction and the organs involved. In mild cases, we might just monitor the patient closely and provide supportive care like pain relievers or fever reducers. But in more severe cases, we might use corticosteroids to dampen the inflammatory response.
Corticosteroids, those are powerful anti-inflammatory drugs, right?
They are. They work by suppressing the immune system, which can help reduce inflammation and improve symptoms. But they also have potential side effects, so we have to use them judiciously.
So it's another balancing act.
Exactly. It's about finding that sweet spot where we can control the inflammation without weakening the immune system too much.
This is fascinating stuff. It sounds like managing iris is like walking a tightrope.
That's a great analogy. It's all about finding that balance between controlling the immune response and allowing it to do its job of fighting the infection.
Well, I think we've covered a lot of ground in this part of our deep dive. We've explored the nuances of MDR-TB treatment, those exciting new drugs, and the complexities of paradoxical reactions. Before we move on, how about another quick quiz to test our listeners' knowledge?
Sounds good to me. Fire away.
Okay, first question. Which of these newer drugs for MDR-TB works by inhibiting mycobacterial ATP synthase? Is it A, bedaquiline, B, preomanid, C, linezolid, or D, ethionamide?
This one tests whether our listener remembers that key mechanism of action we discussed earlier. The answer is A, bedaquiline. It's a powerful drug that targets the bacteria's energy production.
Excellent. Let's try another one. Which of the following is not a potential side effect of linezolid? Is it A, myelosuppression, B, peripheral neuropathy, C, liver toxicity, or D, hypoglycemia?
This one highlights those important safety considerations we discussed. The correct answer is D, hypoglycemia. While linezolid can cause several side effects, low blood sugar is not typically one of them.
Great point. Okay, one last question before we wrap up this part of our deep dive.
Yeah.
Which of the following statements about paradoxical reactions is true? Is it A, iris typically occurs several years after starting antiretroviral therapy? B, corticosteroids are always the first-line treatment for iris? C, iris is always mild and self-limiting? Or D, iris can mimic the symptoms of the underlying infection, making diagnosis challenging?
This one really tests the listener's understanding of these complex immune reactions. The true statement is D. Iris can indeed mimic the symptoms of the underlying infection, which can make diagnosis tricky. It's not always a clear-cut situation.
Right. Sometimes it's like playing detective to figure out what's really going on.
It can be. But by carefully considering the patient's history, clinical presentation, and laboratory findings, we can often make the right diagnosis and initiate appropriate treatment.
Well, we've covered a lot of ground in this second part of our deep dive.
We have.
We've explored the complexities of MDR-TB treatment, delved into the intricacies of therapeutic drug monitoring, and shed light on those perplexing paradoxical reactions.
But there's still more to uncover. Join us for the final part of this deep dive, where we'll shift our focus to the crucial aspects of TB prevention and explore the exciting advancements on the horizon for TB care.
I can't wait to learn more. And as always, dear listeners, if you're finding this deep dive insightful, please don't forget to like, subscribe, and share with anyone who might be interested in learning more about this fascinating and challenging field. We'll see you in part 3. Welcome back to Bugs and Beyond for the final part of our deep dive into TB treatment. We've covered a lot of ground so far, from those powerful first-line drugs
We have.
to the challenges of MDR-TB and those perplexing paradoxical reactions. We've really explored the complexities of this global health challenge.
It's been an incredible journey.
But before we wrap up, I want to shift gears a bit and talk about something that's just as important as treating TB, preventing it in the first place.
Absolutely. Prevention is key when it comes to infectious diseases, and TB is no exception.
So let's talk strategies. What are some of the most effective ways to prevent TB transmission and infection?
One of the most important strategies is early identification and treatment of active TB cases. Remember, people with active TB are contagious, so the faster we can diagnose them and get them on effective treatment, the better we can contain the spread.
Makes sense. It's all about breaking that chain of transmission.
Exactly. And that's where public health programs and contact tracing come in. When someone is diagnosed with active TB, public health officials work tirelessly to identify and evaluate anyone who may have been exposed to that person.
So it's like detective work, tracking down potential cases and offering them testing and treatment.
Precisely. It's a meticulous but incredibly important process that helps protect communities from TB outbreaks.
Okay, so early detection and treatment of active cases, along with contact tracing, are crucial. What else can we do to prevent TB infection in the first place? I've heard of a vaccine for TB.
You're right, there is a vaccine called the BCG vaccine. While it's not 100% effective at preventing all forms of TB, it has been shown to offer some protection, especially against severe forms of the disease in children.
So it's not a foolproof shield, but it can offer some level of defense. Is it routinely given in the U.S.?
Not for the general population. In the U.S., the BCG vaccine is typically only recommended for infants and young children who are at high risk of TB exposure, such as those living in households with someone who has active TB.
Okay, so vaccination is targeted towards those most vulnerable offend. What about other preventative measures, especially for people who might have been exposed to TB but don't have active disease?
That's where latent TB infection treatment comes in. As we discussed earlier, people with LTBI have the TB bacteria in their body, but it's inactive and they're not contagious. However, there's always a risk that LTBI could progress to active TB, especially if their immune system becomes weakened.
Right, it's like that ticking time bomb we talked about.
Exactly. By treating LTBI, we can essentially disarm that time bomb and prevent it from ever going off.
So how does treatment for LTBI work?
It typically involves a course of antibiotics, usually isoniazid, taken for several months to kill off those dormant bacteria.
So it's a preemptive strike to prevent the infection from ever taking hold.
Precisely. It's a highly effective way to prevent TB disease in people who are at risk.
Okay, so we have early detection and treatment, contact tracing, vaccination for those at high risk, and LTBI treatment. Those are all important medical interventions. Are there any other factors that contribute to TB transmission that we need to be aware of?
Absolutely. We can't talk about TB prevention without addressing the social determinants of health.
That's a great point. What are social determinants of health and how do they relate to TB?
Social determinants of health are the conditions in which people are born, grow, live, work, and age. They include factors like poverty, housing insecurity, food insecurity, lack of access to healthcare, and systemic racism.
And these factors can increase the risk of TB transmission.
Unfortunately, yes, TB disproportionately affects marginalized communities that face these social and economic challenges. Overcrowded living conditions, malnutrition, and limited access to healthcare can all increase the risk of TB transmission and make it more difficult to control the spread of the disease.
So it's not just a medical issue, but also a social justice issue.
Precisely. We need to address these underlying social and economic factors to create healthier environments and reduce TB transmission rates. It's all connected.
That makes a lot of sense. It's about taking a holistic approach to TB prevention, addressing both the medical and social aspects of this complex problem.
Exactly. Now let's shift gears a bit and look towards the future. What's on the horizon for TB care? Are there any exciting developments in research and treatment that give us hope?
I love a good dose of hope. What's brewing in the world of TB research?
One area of intense research is the development of new and improved diagnostic tests. The current TB tests, while helpful, have limitations. They can be slow, require specialized equipment, or may not be sensitive enough to detect all cases.
So there's room for improvement. What kind of advancements are researchers working on?
Scientists are exploring a variety of innovative approaches, from molecular diagnostics to breath tests and even artificial intelligence algorithms. Imagine a simple rapid test that could be used at the point of care to diagnose TB quickly and accurately, even in remote areas with limited resources. That would be a game changer.
I can see that a point-of-care test would be a huge step forward in TB control efforts. What about new drugs and treatment regimens? Are there any breakthroughs in the pipeline?
Researchers are working tirelessly to develop new drugs that target TB in novel ways with the goal of overcoming drug resistance and shortening treatment durations. Imagine a world where TB treatment is shorter, less toxic, and more effective even for the most challenging cases.
That would be a dream come true. It sounds like the future of TB care is full of promise.
It is, and it's not just about new drugs and diagnostics. Researchers are also exploring host-directed therapies, which aim to boost the body's own immune defenses against TB.
Host-directed therapies. That sounds intriguing. How do they work?
Instead of attacking the bacteria directly, these therapies focus on strengthening the immune system's ability to fight the infection. It's like giving the body's natural defenses a power-up.
So it's like a tag team approach, combining the power of drugs with the body's own healing mechanisms.
Exactly. Host-directed therapies could be particularly helpful in cases of drug-resistant TB, where traditional antibiotics are less effective.
I'm sensing a theme here. Innovation is key in the fight against TB.
You're absolutely right. We need to be constantly exploring new approaches, pushing the boundaries of scientific knowledge, and collaborating across disciplines to find solutions to this global health challenge.
Well, I think we've reached the end of our deep dive into TB treatment. It's been an incredible journey exploring the complexities of this ancient disease, from those powerful first-line drugs to the challenges of MDR-TB, and the hope that lies in new research and a commitment to public health.
It's been a pleasure sharing this knowledge with you and our listeners.
And remember, dear listeners, if you enjoyed this deep dive into the world of TB treatment, please don't forget to like, subscribe, and share it with anyone who might benefit from this knowledge. Until next time, stay curious, stay informed, and stay healthy.